Okay, so this is part 2. So first is we are going to discuss about Pseudomonas aeruginosa. So this is known for being a hospital-acquired infection, especially those in immunocompromised patients. So, what's immunocompromised naman, no? So, they are an opportunistic pathogen because due to they have biofilm formation and resistance to multiple antibiotics. So anong meron sa kanila? Exotoxin A, elastase, pycinin, efluxpums. We diagnose this through culture and McConkey agar oxidase test pigment production. We treat this with piptaz, piperacillin, tazobactam, ceftazidime, and aminoglycosides. So your Pseudomonas aeruginosa is a gram-negative, oxidase-positive, non-fermentative, smooth round colonies, grape-like odor. There are two types of pigments, no? Si Pseudomonas, very important that you know. Pyocyanin, it's a non-fluorescent bluish pigment, and verdin, fluorescent greenish pigment. Okay. So, the pathogenic properties of your Pseudomonas aeruginosa would be your pili or fimbriae that promotes attachment, lipopolysaccharide, extracellular enzymes like your elastase, protease, hemolysis, and exotoxin A that causes tissue necrosis. So, clinical infection, this is a nosocomial pathogen. Pag na-infect ang wounds and burns, they produce a blue-green pus. So, they can also cause meningitis pag na-introduce through lumbar puncture. So, it can also cause UTI pag na-introduce sila by catheters and instrumentation. Respiratory tract infections from contaminated respirators causing necrotizing pneumonia and chronic pneumonia in cystic fibrosis patient. So, it can also cause eye infections, otitis media in your ear, septicemia in infants and those with leukemia or lymphoma receiving chemotherapy, hemorrhagic necrosis of the skin, that's called your ecthyma gangrenosum. So, we treat this using piperacillin plus aminoglycoside, asternam, carbapenems, fluoroquinolone, ceftazidime, cefalporazone, and cefepime. Okay, one of the most important is your Mycobacterium tuberculosis, of course. So this is the causative agent of your tuberculosis, a very major public health concern, especially here in the Philippines. So we get this through inhalation of airborne droplets. They survive and replicate within your macrophages. So ano meron sa kanila? You have your mycolic acid cord factor intracellular survival. So we diagnose this through acid fast stain culture, polymerase chain reaction, tuberculin skin test. So now ang nasa guidance talaga is for TB patient, we do gene expert. Okay, then we treat these using your isoniazid, rifampin, pyrazinamide, and ethambutol. Okay, so human is the only natural reservoir. These are intracellular obligate aerobes. They are non-spore forming, non-motile bacillus with high cell wall content of high molecular lipids. Curved rod 0.3 to 0.6 um by 1 to 4 They are usually beaded in appearance. They are weakly gram positive or gram null colorless. They are strong acid fast, no? You always remember that strong acid fast. They are slow growing, 15 to 20 hours of generation time. Viable growth in culture is 3 to 6 weeks, and there is a serpentine cording culture in growth pattern. So mode of transmission, it's of course, these inhalation of the droplet nuclei, infectious particles, aerolized by coughing, sneezing, or talking. No, there are 3,000 infectious droplet nuclei na cough. 10 bacilli lang may initiate infection. Prolonged exposure and multiple aerosol inocular required. So, mga virulence factor na meron sa kanya, they have a cording factor. This inhibits migration of your neutrophils and they elicit granuloma formation and mycolic acid and also damage your mitochondria. They elicit serpentine cord pattern of growth, indicate that um, that indicates pathogenicity na. Sulfatides, they inhibits phagolysosome formation, and it has antibacterial resistance. So, anong mga risks of infection? Closeness of contact, infectiousness of the sore, morbidity factors, risk of infection, risk of developing active disease. Periods of life at risk, mga infants, 15 to 25 years old. Ayan. So, pathogenesis first is you have your initial focus. So, subpleural, in your subpleural mid-lung zone, the lower parts of the upper lobes of your lungs, and the upper parts of the middle or lower lobes, no? So, subpleural siya. So, I don't know if ma-appreciate yung pa sa inyong anaphysia. Post-primary PTB, reactivation, high oxygen tension, low lymphatic drainage. Okay, so gone complex. There is cellular immunity plus tissue hypersensitivity. Nagkakaroon siya ng positive tuberculin test, no? 3 to 8 weeks after infection. So, you're gone complex. This is a subpleural fissure focus of inflammation. Infected lymph nodes draining the primary subpleural lesion. So, Ranke complex and your Simon foci. So, huwag niyo na masyado yan anuhin. So, clinical presentation. So, primary tuberculosis in childhood usually is found in the mid-lung zones. Fever, lassitude, extensive regional adenitis, brassy cough, atelectasis of segmental lobe, symptomatic pneumonia, lymphomatogenous dissemination. So, any pneumonic infiltrates associated with the hilar or mediastinal nodes or in unusual location, consider primary TB na. So, in adolescents and adults, primary TB after childhood may occur without symptoms, signs and symptoms, typical primary complex, and typical pulmonary TB. Okay, so the signs of symptoms, you have your fever, malaise, weight loss, night sweats, no? Nagkaka-fever ka, ginakapoy ka, naga-weight loss. Ang pasyente, no? Nikalit sila kapayat. Tapos pagkagabi kay ginapaningot sila. Of course, nagaubo-ubo sila. Ang uban, nagalisod, nagkinhawa, no? Dyspnea, no? O nagasukan na og dugo. Pero ang ilang physical exam, no, dili kay nimo sila maingon non-specific ang mga PE kay makitan man nimo ni sa laing mga sakit. Pero diri sa Pilipinas, no, pag makakita na kog ing-ani, of course, no, dapat i-refer na nimo sila na magpa-test for TB. Kay most likely na gid sila TB. So, pulmonary tuberculosis, clinical diagnosis with radiographic evidence, positive skin test, laboratory detection of the organism. So, pag sa x-ray, no, there is a middle or lower lung lobe infiltrates with ipsilateral hilar adenopathies in primary PTB with cavitation in primary progressive PTB. So, most frequent size apical posterior segments of the right upper lobe and apical posterior of the left upper lobe. We can also do your tuberculin test. Okay, so, ito na ang ginagawa natin. It's purified protein derivative, if I'm not mistaken. Okay? So, technique is multiple puncture. Huwag na yan. Pang medtech na yan masyado. Ito, ano to? You can also get a false positive test, no? Because of the BCG reaction and naturally occurring non-tuberculous myobacteria, pwede ka naman magka-false negative pag inexperience yung gumagawa ng test. Loss ng antigen potency, concurrent infection, meron naman siyang HIV viral bacterial and live virus vaccination, diseases affecting lymphoid organs, immunosuppressive drugs, age, no, newborn, elderly, recent surgery and birth. So, pwede siyang makakos ng false negative sa test. Then, pwede naman siya false positive pag naturally occurring na non-tuberculous mycobacteria at saka reaction sa BCG. So, how do we test? No? First is your sputum microscopy, AFB sputum smear exam. So, we use your carbolufusin stain. And we use the Ziehl-Nielsen or Kinyon technique. So, Ayan, tandaan nyo lang to, Zilnilsin or Kinyon technique. And acid-fast staining. No? Smear is positive if at least 2 specimens are seen, no? Per right now, ito, masyado na tong pang medtech, pero baka lumabas to sa exam niyo, Lowenstein Jensen, Middlebrook 7H10. Pero ang dapat yung malaman right now is ginagawa natin gene expert. Okay, so gawin na lang natin yung assignment. What is gene expert? Ito, ipapa-assignment ko na lang dito kasi hindi na to recent. Okay, so ito yung sinasabi kong BCG kanina, Bacillus calmette and guarino. We give this to the newborn. So, especially pag namo sa health center, no, maka-administer, give mo ani. So, for tuberculin negative subjects, does not prevent infection, pero, no, it prevents complication of TB. Okay. So, dito lang, no, dapat malaman nyo lang silang assignment na ko ang treatment o what is gene expert. Okay, next is Clostridium difficile. Why is this clinically significant? This is responsible for antibiotic-associated diarrhea and pseudomembranous colitis. So, this disrupts your normal gut flora by antibiotics and toxin production. Anong meron sa kanila? Toxin A and toxin B. We diagnose this through stool toxin test, PCR. We treat this using metronidazole, oral vancomycin fecal microbiota transplantation. So, this is cause of 25% of the antibiotic-associated diarrhea. Yung mga persons na who are receiving antimicrobial drugs for several days. So, nasa-suppress yung normal flora and replaced by drug-resistant organisms. So, your pseudomembranous colitis, this is the antibiotic-induced proliferation na ng C. difficile. So, there are two types of toxin. Your toxin A, potent enterotoxin, toxin B, potent cytotoxin. They have glycosyl transferase activity results to apoptosis, capillary leakage, cytokine stimulation leading to colitis. The toxins will be found in the stool of the patient. So, ayan siya. When you do colonoscopy, so there are raised adherent yellow plaques that vary in size from 2 to 5 millimeters that are visible in the colonic mucosa. Okay, next is here the Neisseria gonorrhea. So, why is this significant? No, this is a common sexually transmitted infection. Why? Because it adheres to and invades mucosal surfaces and invades immune response. Anong meron sa kanila? Pili, opacity proteins, IgA, and protease. We diagnose this through gram staining of the discharge, culture on Thayer-Martin agar, and nucleic acid amplification test. We treat this using, very important na you remember this, ceftriaxone plus azithromycin or doxycycline. Ayan. So, kailangan lang natin ng urethral discharge or vaginal cervical swab, pwede din throat swab. So, your Neisseria gonorrhea is a gram-negative intracellular diplococci. Yan o, gram-negative intracellular diplococci. Next species is your Salmonella species. So, why is this significant? This causes foodborne illnesses including your typhoid fever and gastroenteritis. So, why no? Because of ingestion of contaminated food, water, invasion of intestinal mucosa. The virulence factors would be your type 3 secretion system and endotoxin. So, we diagnose this through stool culture, blood culture for typhoid fever, serotyping, and we treat this using fluoroquinolones, azithromycin supportive care for gastroenteritis. So, general properties of your Salmonella species. They are non-lactose fermenter, meaning they are colorless on the McConkey agar. And they produce H2S from sulfur-containing amino acids. So, clinical importance. Fecal oral transmission. Eggs and poultry. Reservoir would be your human carriers. No? So, and turtles. Okay, turtles. So, pag nagkaka-gastroenteritis sa Salmonella species, they are usually due to Salmonella enteritis and S. typhimurium. So, nagkakaroon ng fever, cramping, abdominal pain, nausea, vomiting, and non-bloody diarrhea. Pero this is a very self-limited. So, no, you need to know your enteric typhoid fever. This is due to Salmonella typhi. This is a very severe life-threatening systemic illness. Non-specific lang ang iyang mga symptoms na chills, sweat, cough, headache, sore throat, anorexia, myalgia, rose spot. And ang complications niya is intestinal hemorrhage, pneumonia, cholecystitis, severe bleeding, and psychosis. So, initial constipation first week, no, sa first week. Later, nagkakadiarrhea ka on the third week. Pero you have bacteremia from the beginning. So, laboratory, blood culture, initial phase of enteric fever, stool culture, diarrheal phase, antibody detection. We treat this using B-lactam and fluoroquinolones. So, we prevent these, no, by proper sewage disposal and correct handling of your food and good personal hygiene. Okay, next is your Klebsiella pneumoniae. So, this causes pneumonia, particularly in patients with weakened immune system. How do we get this? By aspiration of colonized oropharyngeal secretions. They are also capsulated by adhesins and siderophores. So, we diagnose this using sputum culture, blood culture, gram stain, and we treat this with carbapenem, cephalosporins, and aminoglycosides. So, Klebsiella belongs to your Enterobacteriaceae, no? They are short gram-negative rods with capsule Friedlander's pneumonia. So, alcoholism is the most common underlying cause. So, can also be seen, no, sa patients na may diabetes and COPD. They are very at risk. Aspiration as precipitating cause, pharynx ng mga alcoholics are colonized. So, manifestation includes sudden cough, pleuritic chest pain, nahihirapan huminga, dyspnea, high-grade fever, chills, and the most important buzzword of all, Klebsiella, is your currant jelly sputum. Hold on, saglit lang. Okay. Sorry. So, ayan, your currant jelly sputum. Hindi yan current. Okay. So, Klebsiella pneumoniae is present in the respiratory tract and feces of about 5% of normal individuals. It can also cause urinary tract infection and bacteremia and hemorrhagic necrotizing consolidation of your lungs. Yan. So, we diagnose this, no? Sa x-ray. No, hindi. Ano lang to, hindi to siya, you know what, this slide is very, hindi pala. No, makita mo siya sa x-ray na pwede mo masabi na may pneumonia. Pero, hindi mo naman ma-identify na iyan si Klebsiella pneumoniae. Okay? Then, sa CBC niya, no, the leukocyte count can be normal, pero neutropenia would be an ominous sign. Okay. Next, and last and not the least, would be your Haemophilus influenzae. So, what would be the clinical significance of this? Can cause respiratory infections and meningitis, especially in children. It colonizes your nasopharynx and can invade your bloodstream. So, ano meron sa kanya? Capsule and IgA protease. We diagnose this with culture and chocolate agar and PCR. We treat this using ceftriaxone, amoxicillin, clavulanate, HIV vaccine for vaccination. So, your Haemophilus influenzae is the most common cause of meningitis of children na 6 months to 2 years old. It's a gram-negative short rod, no? Non-spore-forming, non-motile, facultative, anaerobe, fastidious. No, meron silang factor X and factor V. So they have a capsule, a membrane lipo-oligosaccharide, no, for attachment invasiveness, paralysis of ciliated respiratory epithelium, and IgA protease. So, the portal of entry would be your upper respiratory tract na disseminate siya from bacterium from RTI focus and direct propagation pag na-head trauma ka, infection ang imuhang ears, no, otitis media, CSF leak. So, host defense, no, na sila anti-capsular antibody. Kita, no, pwede ta para malabanan tong capsule. Okay, so this is strictly human pathogen. Mode of transmission is your droplet inhalation. Susceptibility, humoral immune deficiency, mga sickle cell disease, chronic pulmonary infection, and splenectomy kay dili na nila ma-fight off. That's why sa mga patients nga na splenectomy, Hib vaccine is very important. So, we treat this empiric treatment, ampicillin plus chloramphenicol or third-gen cephalosporin. Specific would be your ampicillin or amoxicillin, third-gen cephalosporin, and chloramphenicol for penicillin resistant. Prevention, very important would be your Hib vaccine. Then prophylaxis would be your rifampicin. Thank you so much.